I think we're all set to get started. Um, Thank you all for attending the webinar today, co-hosted by EGFR Resistors and Young Lung Cancer Initiative. Um, and it's covering the role of surgery in stage 4 oncogene-driven lung cancer. My name is Mike Troy. I'm a patient advocate with the EGFR Resistors. I'm joined by my co-host today, Leah Phillips. Leah, if you'd like to introduce yourself.
Hi, yes, thanks, Mike. My name is Leah Phillips, and I am a stage 4 EGFR lung cancer patient diagnosed in December of 2019. I'm also one of the 3 originating founders of Young Lung Cancer Initiative, which is a nonprofit that we started to help give visibility to those diagnosed with lung cancer under the age of 50, and also the hope and empowerment. So we have a website and on our social media. So if you want to learn more about what we do, we're on TikTok, Instagram, Facebook, and that might be it. And also our website.
Excellent, thank you. So we're delighted to be joined today by Dr. Carl Gray and Dr. Mara Antonoff. Dr. Gray is a thoracic oncologist and assistant professor at the Department of Thoracic, Head and Neck Medical Oncology, and the Division of Cancer Medicine at the University of Texas at MD Anderson. He's an expert in small cell lung cancer, neuroendocrine transformation, among other things. So we're delighted to have him. Also joining us is Dr. Antonoff, who's a thoracic surgeon, an assistant professor, and assistant program director for education at MD Anderson. Dr. Antonoff is certified by the American Board of Thoracic Surgery, and her specialties include a concentration on thoracic oncology, lung transplantation, excuse me, and an emphasis on minimally invasive surgical techniques. Both are experts in their field, so we are really grateful to have them with us. I think before we turn the floor over to Dr. Antonoff and Dr. Gay, I just wanted to begin with a quick word of thanks to both of them and their colleagues at MD Anderson for conducting the research that they've been doing in stage 4 patients. Stage 4 oncogene-driven lung cancer isn't really an area where we see a lot of these sorts of efforts aimed at curative treatment. And I know that there's a lot of sort of institutional inertia against these kind of trials. I remember particularly at TTLC 24, someone made a joke, which I actually think was directed at MSK, but I guess originally aimed at MD Anderson. And it went something along the lines of, we all follow the data, and then there's MD Anderson and they follow their intuition. And I thought sort of immediately the more appropriate line would have been that, some follow the data, others make the data. And I think I speak on behalf of everyone on this call, that we're really grateful to you both and all your colleagues for trying to aim for sort of curative intent treatment in stage 4 disease. So thank you both.
Thank you so much for having us here. It's a real pleasure. And I think I speak for Dr. Gay and myself when I say that we 100% agree with everything you said. We enjoy pushing the envelope and really trying to change the data so that we can broaden horizons and opportunities for patients going forward in the future. So thank you so much for having us both.
Yeah, thank you. And with that, I guess we can just turn the floor over to you two and
Wonderful.
cover your presentations.
Yeah. So again, I'll echo Dr. Antonoff's sentiment just in the pleasure it is to speak to you all here today. And I think talking about an approach to this disease and other similar diseases that maybe is not the standard of care and is not conventional now, but one that I think is kind of gaining momentum. And it's really been a pleasure. MD Anderson is the only place I've ever worked, I've ever trained as an oncologist, and so this is just commonplace to me. And so it's always interesting for me to see how these diseases are managed outside. But yeah, this notion of local consolidation therapy and the role that it might play in patients that have driver mutant non-small cell lung cancer is something that's near and dear to all of our hearts. And so, you know, I think the big question that we're posing today is there a time or a patient type with stage 4 non-small cell lung cancer, EGFR, or other similar very actionable driver mutations where curative intent therapy, right, definitive local therapy is appropriate? And I don't need to tell anybody on the call that non-small cell lung cancer and the landscape has changed a lot in the last 20 years. You know, we went from sort of a holistic approach to this disease to one where we're biting off smaller and smaller slices of the pie. And this has been a tremendous success, right? But I don't think it's certainly not a time to rest on our laurels and say, all right, we've got, you know, TKIs for most of the driver oncogenes. I think we're good, right? There's clearly room for improvement. And just to emphasize that, you know, here looking back at the FLAURA data, obviously now we have the FLAURA2 study, but the fact remains that whether it's osimertinib alone or osimertinib plus chemotherapy, while patients do better now than ever before with EGFR mutations, there are still challenges that we face, particularly in the metastatic setting. I think there's been some really exciting data with AD-AURA and then very, very recently with LAURA, suggesting if patients are captured earlier, that we can really, really do something to prevent the disease from recurring. But that's not the typical case, right? The majority of patients with EGFR mutations are unfortunately still diagnosed when they're in the metastatic setting. And so we need to find some way to delay resistance or even prevent resistance. And so I think of there as being a series of unmet needs for patients that have EGFR mutations, particularly in the metastatic setting. And we have good targeted therapy, but resistance is still commonplace. And the resistance we assume is coming from the fact that we don't eradicate the entirety of the disease with osimertinib or whatever TKI, that we're still leaving residual disease behind, and this residual disease will ultimately be a nidus for resistance. And the resistance mechanisms are very heterogeneous. And so once resistance takes hold, it's much more difficult to target or personalize the therapies that we would provide for these patients. And the salvage options that come after are much more limited than what we can offer in the front line. Now we're getting better there, but I think there's still clearly room for improvement. And so the question is, can local consolidation therapy, radiation, or especially in the context of this talk, surgery, can that potentially either eliminate or at least delay the resistance to the frontline standard of care? And so if we think about non-small cell lung cancer as a whole and a role for local consolidation therapy, this is sort of the gold standard that first illustrated that there may be something to this, right? And so this is a trial that we often refer to as the Gomez trial. And basically the question asked here, and I won't belabor a lot of the detail in these trials today. I think we want to focus on big picture. But basically the question is, if you have a patient that has relatively modest metastatic disease, in this case, 3 or fewer sites of metastatic disease, and you treat them successfully with therapy, they don't progress, continuing that therapy versus stopping at some point and consolidating it, either with, probably with radiation in many of these cases, but also considering surgery to eliminate whatever's left behind of the disease. And this demonstrated that patients that got that sort of local consolidation therapy, they lived longer. And so, overall survival benefit was there, suggesting that rather than just continuing what got you there, actually pausing and doing something more aggressive about it to consolidate it might be beneficial. This is far from a settled debate, though, right? I highlight these 2 editorials from the Journal of Thoracic Oncology just late last year, where there was sort of a point-counterpoint arguing in favor and against local consolidation of oligometastatic disease. As was noted in the introduction, MD Anderson has really, I think, preached this, in the decade plus that I've been at MD Anderson and even before that. But there is still some variety of opinion out there, and so I'll review some of the data in favor of this, and Dr. Antonoff will really focus on the role that surgery plays in these patients and some of the nuance that comes with patient selection and her unique experience in treating these patients surgically. A lot of the data we have for local consolidative therapy in EGFR patients is limited to small case series, bordering on anecdotes, right? And so these are a few series highlighting the fact that there seem to be improved outcomes if patients received some form of local consolidation therapy, whether it be with radiation, which is more common, or surgery. But again, the first study limited to just 12 patients that got local consolidation therapy. This was primarily at MD Anderson. The next study, 14 patients. Third study, up to 50 patients now. So we're getting better as time goes on, but these are still small case series, arguing in favor, but not definitively showing evidence of this. I want to introduce a couple of cases of my own that I share with Dr. Antonoff, just to illustrate the paradigm that we followed at MD Anderson for these patients. So the first patient, 67-year-old gentleman, lung adenocarcinoma, metastatic to multiple bony sites, EGFR L858R. This was diagnosed, I first met him back in October 2019. He started osimertinib at that time, and he started it on a trial called the North Star trial that you'll hear about shortly. He had essentially a metabolic complete response on PET, and shortly after that, he underwent a surgical resection to his residual thoracic disease. His bony disease had all completely resolved based on PET, and he had only 10% of his tumor was viable, but that's 10% of tumor that was eliminated based on the surgery. He then resumed osimertinib, and he's never had any local or recurrence to date, and that's current through this month. Another similar case, 53-year-old female, diagnosed July 2020. Again, this patient had both brain and bone metastases in addition to their thoracic disease. They had a metabolic complete response on a PET, and nearly a complete response in the brain on MRI. Underwent a resection to the residual disease in the thorax, resumed osimertinib, and remains NED. And so these patients have had a much longer progression-free survival than we would ordinarily expect with osimertinib alone. You know, I mentioned anecdotes earlier, and that's exactly what these are. But I'll put these into the context of the greater protocol and some of our other protocols that were similar. So I mentioned the North Star trial. You're going to hear a lot more about this from Dr. Antonoff. But basically, this was a study in which everybody that was newly diagnosed with EGFR mutant lung cancer had a typical EGFR mutation, like an L858R, an exon 19 deletion. They were initiated on osimertinib, and provided they did not progress on osimertinib within the first 12 weeks, they were then randomized to either just continue osimertinib, which would have been the standard of care at that time. This is pre-FLAURA2, right? Or to pause to get local consolidative therapy, either via surgery and or radiation, and then resume osimertinib only after that. And so this is a breakdown of some of the local consolidative therapy strategies that have been used there, and the sort of broad strokes of the safety. And so you can see a number of patients underwent consolidation on this protocol, many of which got radiation, but 24 of which got surgery, which is a huge number to get surgery in the metastatic setting. You'll hear much more detail about this from Mara, but the surgery proved by and large very, very safe. Did not seem to introduce additional risk, which is obviously the forefront of our mind when we do something a bit outside the box like this. And similarly, radiation proved to not introduce a lot of additional toxicity, particularly in the realm of pneumonitis, which was a concern considering there's some risk of this with Tagrisso alone. This is a greater breakdown of the adverse events or safety. I don't expect anybody to zoom their screens in. The point here is that there were no severe AEs here, right? There were no grade 4 or 5 toxicities, meaning no one died as a result of any of the interventions on this study, and no one faced a real life-threatening consequence. And so the important take-home point here is that it proved safe. We had another similar study called Bright Star. We're getting ready to have another study called Bright Star 2. This was in the ALK fusion space. Another common driver mutation that we see in young lung cancer patients. Design was very similar here with one key difference. So the patients all got brigatinib, which is one of the ALK TKIs up front. These patients were not randomized, however. All of these patients received local consolidative therapy, provided they did not progress and there was not some contraindication to doing it. And these are the outcomes that we see in BrightStar, looking at progression-free survival and how they compare to patients. This is a cross-trial comparison with patients that would just be treated with brigatinib alone on study, right? And so at each time point, 1 year, 2 year, 3 years, comparing across trials, these patients that got local consolidative therapy had a higher rate of progression-free survival than patients historically that have been treated with brigatinib alone. Zooming in on this, and I think there's some very interesting take-home points here. We looked at whether there were patients that did particularly well with local consolidative therapy. And we saw some key distinctions here. And I think patient selection is going to be something that's very, very important if we think about deploying particularly surgery. We found patients that had fewer metastases at baseline. So oligometastatic disease is 3 or fewer metastases. Those patients had a much higher rate of progression-free survival with local consolidative therapy than patients that had more widespread. In fact, none of the patients, as you can see, that had oligometastatic disease had progressed at 4 years. The extent of local consolidation therapy, meaning could these patients get all of their disease sites eradicated by surgery or radiation, or only some of them, seem to make a difference, right? The patients, unsurprisingly, that got complete local consolidative therapy did better overall. And then I think another really interesting point, and something that's really, I think, at the forefront of a lot of our minds when we think about how to risk stratify patients with these diseases, is that the patients that were able to clear the ALK fusion in their bloodstream, right? That they did not have circulating tumor DNA that had that where you could detect the ALK. Those patients prior to LCT, if they'd already cleared the ALK fusion, those patients did better than the patients who had not entirely cleared the ALK fusion. So I think this gives us some hints as to the sort of patients. I think the argument today is not that local consolidative therapy is for everyone necessarily. I think there is a Gestalt approach here that's hard to define, but you kind of know it when you see it. That said, we need to define some elements of the cases where we think, especially surgery, if you're going to introduce something as challenging as surgery to patients, where we're selecting the patients that are most likely to benefit from it. And so I just want to briefly pause and offer some conclusions on my end as a medical oncologist, and then I'll turn it over to who I consider to be the star of the show here, the surgeon that's really going out on a limb and offering these unconventional surgeries. I'm doing the standard of care and certainly supportive of these surgeries, but I think Mara is really a pioneer in what she's doing. So my conclusions for the group are that we've come a long way in targeted therapies, and we continue to improve this. Right now, we add chemo to targeted therapies. We have amivantamab that we can offer to patients that might be progressing, and that seems to be reversing a lot of the resistance. But still, we are not routinely curing metastatic patients with our personalized therapies. And the longer we leave residual disease behind, and the more residual disease we leave behind, presumably the more likely we are to experience the emergence of resistant clones. I think we've shown that radiation and surgery for these patients in the metastatic setting is safe. We've shown preliminary evidence that it may be beneficial, and very soon we expect to have more definitive evidence from North Star, hopefully showing that the patients that underwent LCT are actually doing better. With that, I'm going to turn it over to Mara. My brief conclusion from my part is that absolutely yes, local consolidative therapy is appropriate for the right patients. And I'll let Dr. Antonoff tell you more about who those right patients might be.
Perfect. Thank you so much, Dr. Gay. I'm sure many of you have questions based on some of the things that Dr. Gay has shared with you, and perhaps you can hold on to them or write them down or share them in the chat. After I'm done presenting, we would love to answer all of your questions. One thing I'd like to bring up before I even jump into the data is the fact that we talk a lot about what the data show about progression-free survival, overall survival. And I think, one of the huge limitations in this space, and why we are so grateful to be speaking to you all, is that we have barely any, if any at all, patient quality of life and patient-reported outcomes in this space. And I think this is something we're lacking substantially, because we can sit here and talk about, quantitative differences in progression-free survival and which groups do the best. But at the end of the day, I think every patient wants to do better than not doing better. And, certainly we can define which patients may be best for local therapy, but we want to be able to offer it to anyone who may be able to receive any sort of benefit. And we want to help understand the benefits that are meaningful to patients, not just the benefits that are meaningful to us. So I hope that we can continue the conversation after we share a little bit more information with you about the feasibility of these types of operations. If you could go to the next slide, please, Dr. Gay. And so, as was shown by Dr. Gay, the landmark oligometastatic trial that came out of MD Anderson in 2016, published in Lancet Oncology with Dr. Gomez as the first author, definitely showed promising results. And again, in that trial, everyone was oligometastatic, so 3 or fewer sites of disease. I do want to point out, just for people who may not be aware, that while we at MD Anderson always use 3 or fewer sites of disease as a definition for oligometastatic, there are some different definitions that are used at other institutions, although we generally feel that 3 is the deciding factor between oligo and polymetastatic. And I also would like to personally emphasize that when we show data that may suggest that patients with 3 or fewer sites of disease have better outcomes than people who have 4 or greater, that doesn't mean that we aren't accomplishing great things in people who may have 4 or 5 or 20 sites of disease. And in general, I think my personal feeling is that what we cannot control with surgery or radiation, if we can control it with systemic therapy, whatever we can do to put all of our skills together, all of our tools together to handle as much bulk of disease as possible, is better than not trying our best to handle it. So, we know that this landmark trial did show promising results for local therapies. And when we looked at our own results of the data, both on and off trial, we saw great outcomes for surgery and radiation. In particular, when we looked at the subgroups of individuals from that trial who had EGFR mutations, we found that they did even better than people who didn't. And we have several important trials that have been described by Dr. Gay, North Star, Bright Star, and other trials in that space at our institution. I think, before I go any further and provide any additional data besides what was shared by Dr. Gay, I will say there are limitations to what we know. We definitely need to explore more, and there are questions that we don't have answers to. We know that our variables of interest in these studies don't center around the technical aspects of local therapy. So we try to guess these technical nuances. Do you need a wedge or do you need a lobe? Do you need lymph nodes removed or not? All of these questions. We're trying to gather these data across multiple patient cohorts, and we're trying to apply elements of early stage disease to advanced disease that may not really be applicable. So I think at this point, I would love to share with you what we already know and what the ongoing knowledge gaps are as we talk about local consolidative therapy. If you go to the next slide, please. So again, we talked a little bit about the Gomez trial, and we aimed, after completion of that trial, to look at our own institution, patients who are treated on trial and off trial, to really figure out who derived the greatest benefit from local therapy. So we used some computing techniques to derive this cohort of patients, of almost 200 patients. Next slide, please. And ultimately, again, use the same definition over almost a 20-year period of patients with 3 or fewer sites of disease. Next slide. And found that patients who had comprehensive local consolidative therapy or local therapy to all sites of disease present at the time of diagnosis had substantially improved survival compared to patients who either just got some of their sites of disease treated or none of them treated with local therapy. So this is obviously very promising, and this has led to a lot of the additional studies that we've done and our increased enthusiasm for offering surgery and radiation in these groups. Next slide. We tried to identify which values or characteristics would make someone more likely to do well after local therapy, such as surgery. We did find that patients who had a non-squamous histology, so adenocarcinoma and other non-small cell lung cancer subtypes, absence of bony metastases, and lesser intrathoracic stage, so lower number of lymph nodes involved, tended to do better after comprehensive local therapy, meaning treatment to all sites of disease. But again, just because we know that some groups do better than other groups, it doesn't mean that there's no benefit to the group patients who may have had some of the unfavorable characteristics. So I don't want to dissuade people who may be concerned because perhaps they had extensive bony metastases. We have seen what appear to be promising outcomes in many individuals in this setting. Next slide. We also wanted to break down really specifically lung surgery in this setting, because in many of these trials, you see either predominantly radiation used for local therapy or radiation and surgery combined, and it's really hard to look at surgery separately. We are currently working on a guidelines from the Society of Thoracic Surgeons to describe best practices in surgery for oligometastatic lung cancer, and we hope to have that publication out within the next few months. However, right now, there are really just limited data in the space of lung surgery. So this is one of the first publications that we did, and this was back about 3 to 4 years ago, looking at the benefits of lung resection in this setting. Next slide. And we found that 90-day post-treatment mortality was very low in both surgery and radiation. And when you look at follow-up for these patients after a median of almost 5 years, we see that median overall survival after surgery was 55 months, after radiation, just under 2 years. I don't want you to try to compare these two curves because we definitely selected those patients on whom we operated, so it's not fair to compare them. I think the main point here is that I hoped that by showing these data several years ago that we could demonstrate to everyone the feasibility of surgery and that this is a real option, and that radiation shouldn't necessarily be the only thing that we consider. We need both tools and we need to use them in a complementary fashion, and that many patients can benefit from surgery to some of their sites of disease and radiation to other sites. Next slide. One of the concerns that comes up is the surgical complexity of operating in this setting. And when we have increased emphasis on this strategy, of course, we've shown that it's feasible and associated with long-term survival. Next slide. But the technical aspects weren't really well characterized. Next slide. And so I wanted to demonstrate how complex these operations are so that we can talk to patients and their families about what to expect, so that surgeons and their teams can know what to expect, so that we can make sure that we can do these operations safely. Next slide. So in terms of intraoperative details of our patients, I will say that the majority of these operations do require being done with a thoracotomy, meaning it's not thoracoscopic or robotic. And I will tell you, people have heard me talk about this, I don't think it matters. We know that when we use nerve blocks between the ribs, when we are respectful of the nerve, when we make small incisions and we have surgeons with small hands, we can do these operations safely. And that's much more important than the size of the incision. But many of these operations do need to be done in an open fashion. Most patients have the lobe removed, although we have had patients who do them with a smaller amount of lung removed. And, we've seen a wide range in the blood loss and operative time for these operations. And one thing I want to point out is that in the surgical literature, when you look at data, it's very common for surgeons to try to describe how complex an operation is by how long it took and how much blood was lost. But the challenge that I have with that is that if you have expert teams doing these difficult operations, you may lose very little blood and get the operation done very efficiently. That doesn't mean that these operations can be done everywhere. And I would argue that there are a lot of complexities to these operations, and I've done a lot of them. And I still find them to be challenging in an exhilarating way because it's great to be able to make a difference and to help people, but they shouldn't be done by someone who doesn't have experience doing them. And next slide, I think will explain why. When we looked at our experience in doing these operations, we see that sometimes we have to change the type of operation. We have to do complicated nuances like getting control of the pulmonary artery. We find that we have to do complex reconstruction. We find that the lymph nodes are very scarred down and adherent to the important structures. Sometimes we need to do more extensive operations, and the surgeons, even at these experienced centers, are reporting these operations as complex and challenging the vast majority of the time. Next slide. However, when we do them in these expert settings, we can get an R0 resection, meaning getting all of the tumor out the vast majority of the time. And the hospital length of stay is very reasonable for someone who's seeking to get local control of metastatic disease. Next slide. These are the complications, and I know Dr. Gay already showed in a different data set the adverse events that we see for patients in these settings. And it may seem like there's a lot of adverse events here, but the most common are development of an abnormal heart rhythm, which is super common after lung resection surgery regardless. It happens in general to be the most common complication we see after lung resection, and it's usually very temporary, as well as prolonged air leak, meaning you have to have the chest tube in after surgery for more than a couple of days. And we see that a lot in this setting. And that's something that I talk to patients a lot about happening in the setting, but these are all things we know how to manage. Next slide. This is what has become very exciting to me, which is the long-term outcomes from surgery as local therapy in this setting. When we look at both perioperative and long-term outcomes using this data set of patients who have had surgery in stage 4 disease, we see really exciting long-term outcomes. If you could go to the next slide, please, Dr. Gay. I love showing people this curve because the blue curve is overall survival and the red curve is survival without any new sites of disease or progression in any way. And I think the important thing to point out here is look at those numbers in terms of time at the bottom. Historically, when we would talk about patients and survival following stage 4 treatment, we were looking at months, not years. And this graph goes out to 5 years. Each of those numbers at the bottom is 1 year, 2 years, 3 years, 4 years, and 5 years. And we are still seeing a substantial number of patients who are alive and well, and many without disease, even out to 5 years after surgery in this setting. So I found this to be incredibly exciting, and I think it offers hope to a lot of individuals. We presented this 2 years ago at the AATS ITSOS conference, and I published it last year in JTCVS. Next slide. So I think we've definitely shown that these operations are feasible and they're safe if performed in experienced centers, and they are associated with a durable long-term overall survival, which is super exciting. Next slide. And again, here's that same survival slide. And I think this really should be considered a foundation for looking at lung resection outcomes in this current era of novel systemic therapies, because when we look at all these data, many of these people got chemotherapy. This was before we had drugs such as osimertinib and alectinib and immunotherapy. And so we expect the outcomes to be even better in patients who have novel therapeutic agents, all these great drugs that Dr. Gay and his colleagues can give individuals to manage any disease that isn't controllable with surgery or radiation. And I think, Dr. Gay's last slide, he mentioned that that we should definitely be doing it when we can get rid of all of the disease, and that we maybe should be doing it when we can't get rid of all of the disease. And my personal feeling is, if you can remove all of the disease, that's great. Ultimately, I think all of the disease either needs to be removable or radiatable or responsive to whatever systemic agent you have. And as these systemic agents get better and better, we don't necessarily need to be able to remove 100% of the disease. If we can take out the primary tumor and prevent the disease from occurring, prevent metastasis to the brain, and treat minimal residual disease, perhaps at the sites of bony metastases with drugs like immunotherapies or osimertinib or other terrific drugs, then I think we have an opportunity to really turn this into a chronic disease like diabetes or heart disease. And I think that's important for us to recognize and to really help people live long and full lives, and people want to continue to have quality of life for another 4 or 5 decades, especially many of the young lung cancer patients that we have the privilege of helping. Next slide. I think there are a number of important questions that we're asking. Can patients with polymetastatic disease be offered local therapy? My personal opinion is I say yes. I did it yesterday and I did it last week, and I operate in this setting with quite a bit of frequency. And I think the rationale is that we have suggested data to consider that we are providing prolonged survival, prolonged disease-free survival. And more than anything, I don't think we can underestimate the huge impact that we have on quality of life. When people don't know and we're guessing based on imaging whether there is persistent disease, whether there is residual disease, was that effusion malignant? Is it still a malignant? Is the drug working or not working? There's so many questions that we don't know. And by making a small incision, we can really get a lot of those answers. And I think that impact on peace of mind, quality of life, and how people carry out their everyday interactions, their job, their parenting, their emotions, their anxiety, how you can get from one day to the next by having answers to some of these questions, I think are pivotal. And it's time for us as clinicians to really be listening to the patients about what is going to be meaningful quality of life to them. Next question is go back 1 sec, please. What is the role of surgical therapy in metastatic disease in combination with novel systemic therapies? Again, my argument is that as we have better and better drugs, I think the role of local therapy gets even greater because we can help even more patients. When we have people with stage 4 disease in whom maybe the drugs aren't working that well, I think it's a okay, there we go. I think when we have drugs that aren't working that well, I think, it's challenging to suggest doing local therapy if there's going to be residual disease that can't be treated. But if the residual disease is going to be easily treatable with the systemic agents and we can get the bulk of the disease out with surgery, I think it only increases the role of treatment like surgical therapy as our drugs get better. So Dr. Gay did go over a couple of these trials, North Star and Bright Star. So if you can go to the next slide, please. This is one example of a patient with North Star. This was a gentleman who actually started off with pain to his shoulder from metastasis from a lung cancer. And he was on this North Star trial that was described by Dr. Gay. Next slide. And after receiving osimertinib, he had a great response to therapy and was randomized to local therapy. And I took him to the operating room. And I do want to mention that there's a lot of scar tissue in these cases. And the challenge in these operations is that the tumor can cause a lot of adhesions, but also the lung itself may be stuck to the chest wall, and we may see lymph nodes that are stuck to the pulmonary arterial branches, which adds to the complexity and really the risk for catastrophe if someone isn't experienced and doesn't know how to do these operations safely. But what we were able to do was to get this tumor out and to remove the lymph nodes. The patient's back on osimertinib and doing well. Next slide. North Star, just an update on this trial. The progression-free survival readout is going to be at 96 events. I think we're currently in the 80s at this point. This is 70s, but we do expect to be reporting all these outcomes very, very soon. And so we're excited to be able to publish these results and to be able to give everyone more information. Next slide. When we look at the individuals who are enrolled in North Star, one thing that I really want to point out, this is important to me, is that, you know, we see that these individuals at baseline and randomization, the majority of them actually had polymetastatic disease. The next slide, I think, shows this figure. Yes, so you can see that those with 3 or fewer sites of disease are in blue, and those with 4 or greater are shown in orange. And before receiving any osimertinib, 70% of individuals had 4 or greater sites of disease. And even after receiving osimertinib and having a good response to therapy, the majority, 59%, still have disease that is at 4 or greater sites of disease. And so I think what this is telling us is that in patients with EGFR mutations who are receiving osimertinib, we very likely can extend these types of local therapy out to individuals who are polymetastatic, more than 3 sites of disease. And I think a lot of our historical data saying that people are going to do better when it's 3 or fewer refers to patients who don't have targeted therapies, who may not have driver mutations, and may have only systemic options that include cytotoxic chemotherapy. That's my perception and my interpretation of the data. Next slide. And so we know that of the North Star patients, 20 of them underwent lung resection, and 90% of them started with polymetastatic disease. The vast majority of them did require thoracotomies. I did a very large number of them. And again, I will tell you, I think that my thoracotomy, my open incision, is a pretty tolerable incision. And the majority of these patients had the lobe removed. Next slide. In terms of the intraoperative findings, again, these aren't easy operations. We reported these operations as difficult 85% of the time. And so if people are considering having surgery in this setting, I do think going to a center that's experienced in these types of operations is incredibly important. These operations still had very reasonable blood loss and operative time, but there's a lot of scarring, a lot of adhesions. Importantly, everyone did well after these operations. Everyone survived. No one went to the ICU. Chest tubes were removed after a couple of days, and the complications totally typical of early stage lung resection, a prolonged air leak in 5% and an atrial arrhythmia in 10%. Next slide. And these are the treatment-related adverse events Dr. Gay already went over, so I think we can go on to the next slide. And I do want to quickly mention this Bright Star case, although, again, this was a different trial that involved patients receiving brigatinib, but this was a young lady who was found to have an ALK rearrangement and received brigatinib. She had extensive nodal disease as well as bony metastases. Next slide. And she had a great response to her targeted therapy. Her operation also very challenging. Pulmonary arterial vessels were stuck to lymph nodes that were stuck to the airways. And interestingly, in this situation, she had no residual malignancy on the pathology. And Dr. Gay and I have shared a lot of patients in this setting where there's either no tumor left when we get the pathology results, or I have to say one of the most satisfying things, and I've had this happen a lot lately, is people who have either 5%, 10%, 2% residual tumor, which means they needed the operation. We got it out. What's left? We didn't go in unnecessarily. However, it gives us a really good feeling about the fact that there's almost no disease left once we take out that primary tumor, and anything that's left is very likely to get destroyed with any ongoing treatment with their targeted therapy. Next slide. We did specifically look at, I wanted to look at the surgical complexity of North Star and Bright Star in aggregate, and tried to do this from a very objective strategy with all these different criteria and a scoring system. And this was done kind of prospectively. And I think, ultimately, I'm going to show you the results on the next slide, and we can go to the next slide. But I think the important thing to recognize is that even though we're calling these cases severely difficult, and there's a lot of scar tissue, and the nodal dissection is impacted, and things are fibrotic, we're needing a lot of advanced maneuvers, we're doing it, and we're doing it successfully. And I think if anyone is interested, they absolutely deserve to have consultation in a center of excellence with experience in doing these operations. And we can talk to you about what the real risks are. But I do hope that it also demonstrates that if you're told by someone who doesn't do these operations frequently that it can't be done, it's very appropriate for them to tell you that it can't be done in their center. And that is probably true if they're telling you it can't be done in their center. But to say that it can't be done in general may be worthy of a second look, maybe from someone who has more experience doing these. Next slide. And then I do want to mention that all the trials we've done are super exciting. Next slide. But our total number is still very small, and not everyone qualifies. And we have a lot of unresolved surgical questions. And I'm very honest with people when I meet them that there are a lot of questions that remain. Next slide. We don't know if the extent of resection matters once it's metastatic. Once the cat's out of the bag, so to speak, does it matter if we take out the whole lobe or if we just do a wedge resection? I will tell you that from my perspective, we are currently going by dogma from early stage disease where we think taking out a lobe is better, but these operations can be really hard. And so I tell every patient that I don't know for sure what I'm going to do. I have a pretty good idea based on the scan, but if I get into the operating room and I can do a wedge resection and the lobectomy feels unsafe, my number one priority is keeping people safe. More than anything, safety is the absolute most important thing. And we don't know that a lobe is better than a wedge in stage 4 disease, but ultimately we want to get the bulk of the tumor out. We don't know the role of removing lymph nodes. And again, I take the same approach. If I can get out a bunch of lymph nodes with a pathologist to look at, to give us information for prognostication and just to get the disease out, I will. But many of these lymph nodes are completely plastered to branches of the pulmonary artery. And if I'm going to put someone's life at risk, it is not worth it because again, a lot of our outcomes are unmeasured or unknown in this setting. And that's why we really need to start doing trials in this space so we can have answers that apply to stage 4 disease, not just that apply to stage 1 or stage 2 disease. We don't know the maximum number of metastases, but I will tell you, I've been operating on people with more and more and more to the point where I'm convinced that we are making a difference. We don't frequently take out the entire lung in this setting, but I have a feeling it's going to happen before we know it. And I've had this comment of malignant effusion on my slides for quite some time about whether we should be doing this in the setting of malignant effusions. And now I feel like I do it all the time in patients who have had malignant effusions, and I'm excited to be able to demonstrate that they no longer do. So that's really a wonderful addition to what we've been able to do for patients. Those previous malignant effusions definitely make it a harder operation, and I have very serious conversations with patients about what it means to operate in that setting, but I will do it. And I think there are other surgeons who will as well. You just have to be prepared for what it requires. There are questions about radiation that we also don't know on how to use radiation and surgery together for the best approach. My personal thought is that if we can operate on the primary tumor, that gives us the most information and we can radiate anything else that can't be removed surgically. And we can also reserve radiation in the setting if perhaps something were to occur down the road. Next slide. So we do have this trial that we're doing right now that at MD Anderson and that we're opening in a couple other places that is really just a registry trial where all these patients that Dr. Gay and I share and that we share with our colleagues, where we're operating on individuals who are not on an interventional trial. We're just tracking the outcomes so that we can begin to answer some of these questions to find out if it matters, whether we take out the whole lobe or just do a wedge or other questions. Next slide. So, in all these areas, we're trying to figure out, does it matter how much we take out, what we do with the lymph nodes, how we combine with radiation, some of these other nuances that are relevant to us. This is a registry trial again, and there's no intervention involved. And it does not preclude people from being involved in other trials that do involve an intervention. Next slide. And I can give more information about this trial to anybody who may be interested. Next slide. But I think, one of the most common questions that I get asked, and I'm thinking you all are very eager to know, is what are our selection criteria for surgery in stage 4 disease? So first of all, people have to be physiologically and medically eligible for surgery. And so what I mean by that is that their lung function tests have to be adequate. There has to be absence of any other major organ diseases that are going to make surgery unsafe, such as kidney failure or having severe heart disease or something else that makes the operation itself unsafe. In general, most of the patients that we end up sharing who have stage 4 disease and have driver mutations tend to be quite young and healthy with really no other medical issues. And so it's been uncommon that we haven't been able to consider someone a physiologic candidate for surgery. This is my answer to Dr. Gay's question, is that I believe that they either need to be in a situation where the sites of disease that are not responsive to systemic therapy or progressive treated with local therapy, and that the sites that will not receive local therapy have options for systemic therapy. So if someone has extensive disease throughout multiple bony sites and I can operate on the lung and their bony sites are responding to osimertinib, great. I think that is someone who meets those settings. And then I will also say that a multidisciplinary discussion is always important in these settings, because we know that this is not all standard of care. So if someone is not an MD Anderson patient, they want to come to MD Anderson and be seen by me to be offered surgery, I will say, wonderful, and can you please see Dr. Gay on the same day, because I want to discuss it with one of my super smart colleagues in medical oncology to make sure he agrees with the plan. And I know he does the same with me. And sometimes he doesn't think surgery is an option, or he hopes, and then sometimes we offer surgery, sometimes we don't. But I think, it's always important to have these discussions. And one argument that I will make, and you will see in the upcoming guidelines that are going to be released, is that one of the guidelines that we can strongly urge is that every patient should have an opportunity to discuss with a surgeon whether they're a candidate. That doesn't mean everyone will be a candidate, but everyone should have the opportunity to discuss whether or not they are a candidate when you have stage 4 disease. And I think everyone has a right to know what their options are and why or why not they might be considered. Next slide, please. So I think, we need more data. We need to consider offering surgery to more patients with oligometastatic disease, but also oligoprogressive disease, polymetastatic disease. We need to track these outcomes. We need to have hybrid approaches that include surgery and radiation. I am not in competition with the radiation oncologist. We are all working together for the same goal. We need to be thinking about competitive attitudes and a team culture, and really thinking about what outcomes are of interest to the patients, their families, and their caregivers, because that's more important than any of the numbers that we can throw in anybody's faces. So I think that is why we are so grateful to be collaborating with you all and speaking with you today. And I just want to thank you very much for giving us the opportunity to be here. And I think, do we have one more slide there, or is that it? Yes. So again, lung resection, I feel very strongly in stage 4 lung cancer. It's feasible, it's safe. We've seen durable long-term survival. I think we need to really reappraise our dogma about how we operate in this setting. Surgeons need to be involved and engaged, and this multidisciplinary progress is really the way to move forward. And I certainly feel strongly that involvement of patients, patient advocacy groups, and caregivers is a huge part of that multidisciplinary progress. So thank you so much. And I think that Dr. Gay and I will be happy to take any questions.
Thank you both for such a informative presentation. I think lots of us patients and caregivers are very hopeful with what you shared. I did want to ask one question that I think the majority of patients would be wondering about, and that is, when we first heard from Dr. Gay about complete medical response to, like, let's say, Tagrisso to begin with, what is considered complete medical response? Does that mean that everything's shrunk? Does that mean that the bones are just sclerotic, but they're still present? Could you just explain to patients what that means?
Yeah, so the two examples that I gave were patients where we did a PET scan after several months on Tagrisso, and those patients no longer had activity that was detectable on the PET scan. And so they may have CT evidence, so there may still be a tumor there, but it's not showing any activity. And so we consider that what's called a complete metabolic response. And those are kind of outlier cases, right? More typically, we see a response, but not necessarily a complete one. And I don't think that that's necessarily the bar that we're expecting to see for patients that would be considered for surgery. And in fact, I know that to be true because, Dr. Antonoff and I have shared many patients that have had a response where the tumor has just shrunk, and she's offered them surgery, and they've done just as well as those patients.
Thank you. I guess my other question is, when we talk about metastatic sites and 3 or more being the standard there, just to clarify for patients that are especially newly diagnosed, when you say 3 sites, does that mean 3 sites as in like bone, brain, and maybe lymph, or does that count as every bone met? Say there's 10 bone mets, is that?
So we pool together lymph nodes that are involved. So all the lymph nodes in the chest count as one site, but then any additional spot counts as an additional site. So if there's one in the clavicle and one in the spine and 2 in the brain, we count each individual spot as not an organ, but we count each spot. So for example, 3 bony metastases counts as 3 spots.
Perfect, thank you. Mike, were you wanting to ask the next question, or would you like me to?
There are a number of questions in the chat. I don't know whether I'm happy to field those, or Mike, if you have specific questions as well.
I think the plan is just to knock out just a few questions that we sort of pre-selected from a list that was submitted, and then we'll end the recording just to maintain patient anonymity, and then we can go through some of the questions in the chat. I think sort of one of the questions I think that a lot of patients have is in terms of induction, the sort of induction systemic therapy, what is the appropriate length? It seems that there's a lot of various opinions out there, and I know that there's maybe no right answer, but it seems like a lot of oncologists say, well, let's get sort of the maximal response, but it's kind of hard to pin down exactly where is the maximal response. I think in Bright Star and perhaps North Star, it was maybe 10 weeks. So do you have a view, I guess, on that?
Yeah, I can certainly offer my perspective there. I think there's a delicate balance, right? I think if we knew a way to predict when the maximal response would be, of course we would wait for that, right? That's less surgery, less radiation that's ultimately going to happen. But as we know from these progression-free survival curves, there's a wide breadth, right? And so I think we typically experience sort of the maximal radiographic response pretty quickly with these drugs, right? And there may be some subtle changes, but there's generally a plateauing effect after, say, 3 months or so on therapy. My personal inclination is somewhere in that 3 to 6 month range is the sweet spot. I think waiting any longer than that, you're running the risk that the patient could have early progression and you may have missed the window. And any shorter than that, you may be neglecting some of the response that's yet to come.
Well, from my perspective, I agree. We don't know when the maximal response is. And from a surgical perspective, from a radiation perspective, I agree that you probably would ideally like to get the maximum response before you radiate. From a surgical perspective, I don't necessarily want the maximum response, because if it doesn't change the operation, let's say I'm going to need to do a lobectomy regardless, changing the primary tumor from 4 centimeters to 2 centimeters, or changing it from 4 centimeters to 3 centimeters, doesn't necessarily change the conduct of that operation, but another 6 months of osimertinib might make that operation even more technically challenging for me. So, from my perspective, I agree that we don't know the right amount of time. I think what I really like to see is that there is control of disease, that it's not rapidly progressing at multiple sites. And if it feels as though we can get the primary tumor safely removed and that the operation isn't going to change with additional response to therapy, then I don't necessarily see a need to continue on for much longer. We don't know the optimal amount of time. And for example, on North Star, we had a set amount of time, but I think I've operated on plenty of patients outside of the trial setting who've been on it for much longer, years. And it's not always easy in those settings. We get through it, but I don't think we know the right answer. And my presumption is that for a patient, it would feel more reassuring to get rid of the bulk of disease before resistance is developed, rather than waiting until resistance is developed. Because I think the notion of becoming resistant to therapy is really frightening for everyone.
Yeah, absolutely. Just sort of following on from that point, in terms of the difficulty, obviously with TKIs, as you explained, there's a lot of scarring. How about for patients that have already been through radiation, perhaps they had SBRT, or even perhaps patients who had concurrent chemoradiation, kind of the full 9 yards of IMRT or something. It obviously it depends on the case, but is that sort of technically still feasible, and is that something that you'd consider?
Sure is. Yep. Just got to go somewhere where someone's experienced and knows what to do.
Okay. One thing that I just think we kind of have to ask is, we all learned recently about the sort of negative results in NRG LU002. Obviously that was in sort of an IO situation, and I don't think they necessarily stratified patients, but how do you sort of reconcile that with sort of North Star and even, I think, Lone Star, right?
Yeah.
I have super strong feelings about this, but shockingly, no, I think, in my opinion, I feel like this is all about study design. When you set a threshold of what's meaningful and you fail to meet that threshold, it's where our statistics become our own worst enemies. And we're saying like, well, we didn't meet the threshold, so now we're going to say that this is an ineffective strategy. And I think that's a problem. I fully believe that's why we see disparate results, because it's a threshold that wasn't reached in that patient population with that strategy in that setting. And that doesn't mean that a different threshold of meaningfulness may not have been reached. That's my opinion. I'd love to hear what Dr. Gay has to say.
I think there are a couple of really important distinctions when we think about the NRGLU002 and perhaps the driver mutant TKI patient population. So I think in the driver mutant patient population, the micrometastatic disease is often the undoing of these patients, right? And LCT offers an escape hatch where that can be eliminated. In patients that are responding to immunotherapy, for example, that there may not be any micrometastatic disease, right? We have patients that appear to be cured from immunotherapy for whom LCT might not offer any additional benefit, but that's virtually unheard of with TKIs. I think the other key distinction is that we have a much greater potential to control the bulk of the disease in these patients that are candidates for TKI. And so you have a greater overall control of the disease at the time of LCT than, say, somebody that's maybe not one of the exceptional responders to immunotherapy and just happens to have one of the transient responses that we see to chemotherapy. So I think they're very, very different disease entities. I'm certainly not going so far as to say that LCT does not play a role in patients that are being treated with immunotherapy or chemoimmunotherapy. But I think it's harder to kind of pin that population down to a single paradigm than it is perhaps for the TKI patient population.
That makes perfect sense. I think the other question that a lot of our viewers have is addressing that sort of minimal residual disease, and both of you, I think, addressed in I know Dr. Antonoff did in your presentation that you're taking out some of this tissue and it has some degree of viable tumor cells still left. I wonder, number one, do you have like a sense? I know we don't have the data, but how many patients that is a factor in, and then also does that tell us anything about sort of the drug tolerant persister cell population?
You're asking all the right questions. These are the answers we still need.
Yeah, I will say we collected a lot of those samples from surgeries and have subjected them to state-of-the-art molecular analyses to see if we can detect whether there's something unique about the cells that are surviving. I think, to reemphasize Dr. Antonoff's point earlier, those cases, even though you find viable cells, I think those feel like huge successes, because you think, goodness, had we not done this surgery, 10% of those cells, which is not a lot, but those were all hanging out there, and one of those was eventually going to become the clone that resisted osimertinib, right? And so I think I think whether it's a complete pathologic response or just a major pathologic response at the time of surgery, I think it's always a win-win here.
Mike, I don't want to interrupt, but we've met our time limit. We have 1 minute left, and want to respect the time of Dr. Antonoff and Dr. Gay. So I'm not sure if you want to wrap things up for us. That would be great.
Yeah, absolutely. Yeah. Thank you, Dr. Gay and Dr. Antonoff, for joining us today and presenting this information. I know for a lot of patients, it was not only tremendously impactful, but also, quite frankly, moving to hear about people who are kind of pushing the boundaries and making what seemed to be impossible possible, and really fighting for patients in stage 4. So thank you very much for all the work you're doing, for joining us today and presenting. And I guess we can work on sort of getting to you both some of the questions that we still have, because I know there was a lot in the chat and time is limited. So thank
really
you both
excellent
again.
Questions in the chat too. Really
Yeah.
good questions. So if you can forward them to us via email or pass along our contact,
Right.
I'm happy to field those.
One possibility might be if they could be collated, then the two of us could work together to answer them, and maybe you could distribute our responses to everyone who registered. And then if they have additional questions, they can reach out to us individually, just so that we can make sure that everyone gets the answers. Because we could answer individual emails, but it might be most effective to kind of collate the questions, let us provide an answer that could be shared with everyone, and then we can answer any remaining questions.
Yeah, that's absolutely something we can do.
Okay. All right. Sounds great. Thank you
Great.
all.
Well, thank you.
Thank you.
Bye.
Bye, everyone.